Welcome to the deep dive. Today we're tackling a topic that's, well, probably crossed your mind, how we manage our medications effectively.
And just as importantly, how we make sure those medications are used safely.
Exactly. My own attempts to stay on top of health info and understand prescriptions, that's really what got me interested in exploring this more.
And it's such a critical area, isn't it? When we talk about medication therapy management, or MTM, think of it like a dedicated service.
Focused on helping patients get the absolute most out of their medications.
Precisely. It's about actively managing them for, better health outcomes.
Right. So to really get a handle on this, we've gathered a couple of key pieces. First up, we have this fascinating study.
The one looking at cost effectiveness.
Yeah, specifically for people on Medicare. And what's really interesting is that it also looks at this across different racial and ethnic groups.
Which is great. It gives us a broader picture of how well these services are actually working for everyone.
Mm-hmm.
And our second source is a presentation from ISMP Canada. That's the Institute for Safe Medication Practices Canada.
Okay.
They're an independent nonprofit focused purely on preventing harm from medications.
And their presentation digs into medication errors, patient safety.
Yeah, and it offers some really insightful ways to think about preventing mistakes, more of a systems approach.
Okay, so our goal today is to really dig into these sources, pull out the crucial bits.
We want to understand why MTM matters, not just cost, but how it fits into that bigger picture of medication safety.
Ultimately, connecting it back to the listener. How might this affect you or someone you care about? Okay, let's unpack this, starting with that Medicare study, the cost-effectiveness one.
Right. So in this study, the researchers analyzed Medicare data from 2016 and 2017.
Okay.
They looked at people 65 and older who had, consistent coverage under Medicare Parts A, B, and D.
And the MTM group.
They were new enrollees in 2017. And they compared them to a sort of similar group, people eligible for MTM, but who didn't actually enroll in either 16 or 17.
How did they make sure the groups were truly similar?
Good question. They used a statistical technique, propensity score matching.
Ah, okay. So trying to create like-for-like groups.
Exactly. Based on a whole range of characteristics, before seeing if MTM made a difference, trying to compare apples to apples, essentially.
That makes a lot of sense. So not just comparing any random groups, they were careful. And how did they measure effectiveness?
Well, they looked at how often people were using their medications appropriately. They used measures from the Pharmacy Quality Alliance for that.
Okay.
And for costs, they looked at total healthcare expenses from Medicare's perspective.
Right.
Then they used some pretty advanced statistical tools to analyze it all and figure out the net benefit of MTM.
Okay, so the big question. What were the main findings? Did MTM actually save money or improve outcomes cost effectively?
Well, the main takeaway, after they considered all those patient characteristics, is that MTM was generally associated with a net benefit.
Across all groups?
Across all the racial and ethnic groups they looked at, yeah. For instance, for non-Hispanic white patients, the estimated net benefit was around $2,500.
Wow.
That's at a specific willingness to pay threshold, of course. But it suggests that, at least in the short term, for the Medicare population overall, MTM seems to be cost effective.
That's certainly encouraging, but the study also looked into whether these benefits were sort of equal across different groups, right?
Yes, exactly. And here's where it gets really interesting. The study didn't find significant differences in those net benefits between minority patients and white patients in the short term.
So what does that mean?
Well, it doesn't necessarily mean MTM isn't valuable for everyone, but it does suggest it might not immediately lead to a reduction in those existing racial and ethnic disparities in medication use.
Right, those gaps we know exist.
Exactly. The researchers themselves point out, we really need more long-term studies to fully understand the impact on disparities over time.
That's a really important point. You can't expect one program to fix complex, long-standing issues overnight.
No, absolutely not.
The study also mentioned how crucial it is to consider the individual health status of patients.
Yeah.
How did that factor in?
Yeah, this was a key insight. They showed that whether or not they accounted for these individual factors, like underlying health conditions, it could actually change the cost-effectiveness results.
Really? How so?
Well, they actually observed that the group getting the MTM intervention had a slightly faster progression of chronic diseases compared to the control group.
Oh, that's surprising.
It is. And it really highlights that when we evaluate programs like MTM, we can't just look at the service itself. We have to consider the health of the people receiving it.
So it's not just about the MTM, but who gets it and what their overall health picture looks like. Interesting. Were there specific patient characteristics linked to benefiting more? Cost-wise?
Yes, a couple of interesting trends there. Older age seemed to be associated with a greater net benefit.
Why might that be?
Well, perhaps because older individuals might be on more complex medication regimens or just have a higher risk of medication-related problems to begin with.
Makes sense.
Also, patients with a lower risk adjustment summary score, which basically means better initial health, they also tended to see a larger net benefit.
So again, the starting health point matters.
It really does seem to influence how much they benefit from MTM, at least in the short term.
And what about factors beyond the individual, like at the community level? Did things like education or access to care in an area play a role?
Absolutely. The study found that counties with higher rates of high school education,
Okay.
lower rates of people without health insurance, and also those outside major metropolitan areas, they tended to see greater net benefits from MTM.
So socioeconomic factors are definitely in the mix.
For sure. It really underscores how access to basic resources can influence how effective these programs are. Interestingly, they also saw a lower net benefit in the Western Census region.
Any idea why?
They suggested it might be linked to lower rates of medication adherence in that part of the country, which makes you think, about how cultural or regional factors might play into health behaviors.
So even with a great program like MTM, the patient actually sticking to the plan, that's a huge piece of the puzzle.
A massive piece.
This all seems to circle back to the original goals CMS, the Centers for Medicare and Medicaid Services, had for MTM, doesn't it?
Precisely. CMS set up MTM, aiming to improve medication use, optimize outcomes, fix medication-related problems, and ultimately bring down healthcare costs.
And this study suggests...
Well, this study, at least in the short term, provides evidence that MTM can be a cost-effective way to work towards those goals for the Medicare population.
Okay, that gives us a really solid grasp on the Medicare study, the economics of MTM. Now, let's switch gears a bit. Let's delve into that ISMP Canada presentation on medication errors and patient safety.
Right. The other side of the coin, really.
Yeah, because even if we manage meds effectively, we absolutely have to make sure they're used safely to avoid harm.
Exactly. And ISMP Canada, as they state clearly, is an independent nonprofit. Their entire focus is reducing preventable harm from medications.
Their mission is safer systems.
Pretty much. Helping create systems where meds are managed safely and reliably, everywhere.
They start by laying out some basic definitions, which is always helpful. Make sure we're on the same page. What are some key terms?
Okay, so they define an adverse event really broadly. Any unwanted, unplanned incident during healthcare. Could be preventable, could be not.
Okay.
Then, more specific. Adverse drug event. That's harm from a medicine, or even from not getting a needed medicine. Includes bad reactions and mistakes.
Right, the errors.
Exactly. They also define safety simply as freedom from accidental injuries. And harm is any impairment, temporary or permanent, body functions, mental, physical pain.
Pretty comprehensive.
Yeah. And finally, a critical incident. That's an event causing serious harm, loss of life, significant permanent loss of function, that sort of thing.
Those definitions really clarify the different levels. Did they share any actual examples, critical incidents?
Sadly, yes. They highlighted some really tragic cases. Mix-ups with heparin, the blood thinner, in newborns.
Oh, no.
Yeah.
Yeah.
Back in 2006, 3 premature babies died after a massive overdose. A mix-up in concentrations used for IV lines.
Devastating.
Then in 2007, a similar error happened with 3 other newborns. Thankfully, they survived. But these are just stark, heartbreaking reminders of the potential consequences.
Truly horrifying. The presentation also brings in a voice from sort of outside healthcare, doesn't it? Dennis Quaid.
Yes, the actor. They reference his keynote at an ASHP meeting back in 2009.
Why him?
He became a really passionate advocate for reducing medical errors after his own children experienced a serious one.
Yeah. Oh.
His point was basically, look, healthcare workers are generally good people trying to do the right thing. But the systems they work in can be flawed. And those flaws contribute to errors. It makes you think about the whole environment.
That really hits home. It's not always about blaming an individual, but looking at the processes, the systems.
Yeah.
What does ISMP Canada say about how common these adverse drug events actually are?
Well, they cite data suggesting that in long-term care facilities, a really significant chunk, somewhere between 42% and 51%, are potentially preventable.
Wow, nearly half.
Yeah. And they also reference a U.S. study and kind of extrapolate from that, suggesting potentially tens of millions of medication errors in pharmacies each year.
Tens of millions, even as an estimate.
It paints a picture, right?
All right.
A widespread issue we need to be aware of.
Those numbers are really eye-opening. When in the whole medication process are errors most likely? Prescribing, dispensing, taking the med.
So ISMP Canada breaks it down. Prescribing, transcribing, like sending the script to the pharmacy, dispensing, and administering.
Okay, the 4 stages.
Right. And interestingly, their data indicates that administration, actually giving the med to the patient, and the initial prescribing stage, those have the highest error rates.
Huh. Not dispensing at the pharmacy.
It might be surprising, yeah.
Yeah.
We often think of pharmacy errors, but it highlights the complexity at both the very beginning and the very end of the process.
So giving the med and deciding what med, those are the riskiest points, which I guess leads right into their discussion about a systems approach to safety.
Exactly. They strongly argue for moving away from just blaming individuals when errors happen
Towards
understanding how the system design contributes. They emphasize, look, healthcare pros need to be competent and careful, obviously. That's crucial.
But it's not enough on its own.
Right. Relying solely on individual vigilance isn't enough. We need to proactively design safer systems, make it harder for mistakes to happen in the first place.
And this is where that model comes in, the Swiss cheese model.
Yes, the latent failure model. It helps us see that errors rarely happen because of just one single mistake.
It's usually multiple things lining up.
Exactly. Multiple weaknesses, the holes in the Swiss cheese slices, each slice being a layer of the system, they all line up just right, allowing a hazard to reach the patient.
So the focus should be on shrinking those holes.
Precisely. Identifying and reducing the number and size of those holes proactively, not just fixing things after an error. Think about barcode scanning for meds in a hospital.
Yeah.
That adds a new layer of cheese, right? With hopefully fewer potential holes for an error to slip through.
That's a really clear visual. They also mention human factors engineering, HFE. How does that fit?
HFE is all about designing systems, tools, processes in a way that considers human abilities and limitations.
Making things user-friendly, essentially.
Yeah, making it easier to do the right thing and harder to make mistakes. Really understanding how humans interact with the tech, the workflows, like designing medication labels that are less easily confused or making equipment intuitive. That's HFE in action.
Makes perfect sense. Design with the human user in mind. So practically, how do we apply the systems approach? Standardization was mentioned, right?
Yes, standardization is key. Standardizing things like drug names, dosages for common conditions, procedures for giving meds.
How does that help?
It reduces confusion and the likelihood of errors. Think about standard order sets for common illnesses or consistent labeling across a whole hospital. Seemingly small steps, big impact on safety.
What about double checks? We hear about having 2 people verify things. Important.
Well, independent double checks can catch some errors, certainly. But ISMP Canada points out they have limitations too.
They're not foolproof.
No. They use a simple example showing that even with checks, an error can still slip through. So while double checks can be part of a safety system, relying solely on them isn't the answer. We need a more layered approach.
Okay, so if we can't just rely on carefulness or double checks, what else is crucial in a systems approach? Incident reporting.
Absolutely essential. Having robust incident reporting systems, easy ways for staff to report unusual occurrences, incidents, especially those causing harm.
To learn from mistakes.
Exactly. Analyzing these reports helps find patterns, uncover system weaknesses, point to where improvements are needed. It's about learning, not just focusing on who was involved.
But people might hesitate to report if they fear blame, right? How do they address that?
That's a huge point.
Yeah.
They strongly advocate moving away from a culture of blame and shame towards what's called a just culture. This encourages reporting by focusing on what allowed the error, not just who did it.
Shifting the focus.
Right. The emphasis is on learning, improving the system. It recognizes humans are fallible, will make errors, but also generally control their choices. A key part is separating the review process finding system issues from any disciplinary action, creating a safe space to report.
That sounds much more effective, more constructive. The presentation also includes a patient's perspective, doesn't it? To really bring home the impact.
It absolutely does. They share a very sad story. A patient with advanced cancer who received a massive overdose of chemo, an infusion error.
Oh, terrible.
The patient suffered severe complications, devastating ones, and tragically died as a result. It's just a stark, heartbreaking reminder of the profound suffering medication errors can cause for patients, for families. Underscores why this safety focus is so critical.
It's a devastating reminder of the human cost. And the presentation ends with a quote from Captain Sullenberger.
Yes, a really insightful one. A smart person learns from his or her own experiences. A wise person learns from the experiences of others.
Hmm.
It really emphasizes looking beyond just our own experience, proactively learning from incidents that happen elsewhere, especially in high-stakes fields like healthcare, to continuously improve safety for everyone.
These safety principles clearly connect to polypharmacy too, which we touched on with the MTM study, patients taking multiple meds.
They do indeed. The presentation briefly mentions a review of clinical practice guidelines on managing meds for patients with polypharmacy.
And what did that review find?
Mostly, guidelines recommend medication reviews that actively involve the patient, and they highlight the crucial roles of primary care doctors and community pharmacists.
Patient involvement is key.
Very key. Shared decision-making, clear communication. But the review also noted that the guidelines often weren't very specific on how to actually implement these recommendations.
So we know what should happen, medication reviews with patient input, but the how isn't always clear.
Exactly. A bit of a gap there in practical guidance sometimes.
What's the main goal of these reviews for someone on multiple meds?
Primarily, make sure all the meds work well together, identify and minimize potential problems, interactions, reduce unnecessary meds or waste.
And the patient's view.
Crucial. Always considering the patient's own perspectives, preferences, health goals. It's collaborative, developing a plan that works best for them.
The ISMP presentation also got into some very practical day-to-day stuff, didn't it? Medication orders, administration, handling supplies.
Yes, they stressed accuracy and completeness in med orders, all the details.
Yeah.
Drug name, dose, route, frequency, instructions, all clearly documented.
And when the med is given.
Detailed documentation then, too. Date, time, who gave it. In hospitals, they have specific definitions for adverse drug reactions, adverse drug events, and need incident forms to document them thoroughly.
What happened? Corrective actions, root cause.
Exactly. Proper labeling of all meds is critical, too. Secure handling and disposal of controlled substances, like narcotics, often needs a witness, specific documentation.
Right.
They also briefly touched on managing medical implants, patient counseling, vendor coordination, recording batch and serial numbers, and verifying purchased medical supplies, checking the order, quality, expiry dates.
And connecting back. Pharmacists playing that key role in MTM and medication reconciliation really ties it all together.
It really does. It brings all these safety and management threads together.
Okay, so let's try and bring everything we've discussed together now. What are the most important takeaways from this deep dive? MTM, medication safety.
Well, first, MTM seems like a valuable tool, particularly for managing costs and utilization in the Medicare population, though we need more study on its long-term impact on racial and ethnic disparities.
Okay, and safety.
Medication errors are clearly a significant concern. A systems-based approach focusing on prevention, good reporting, and that just culture seems absolutely crucial for making healthcare safer. And finally, managing meds effectively, especially with polypharmacy. It really requires structured reviews, clear communication, and active patient involvement in decisions.
So as you're listening, hopefully you take a moment to think about how understanding both sides, the potential benefits of programs like MTM, and the systemic factors behind errors, how that can empower you.
Make you a more informed, engaged participant in your own healthcare.
Or in the care of someone you love, yeah. Maybe consider having a really detailed chat about all your meds with your doctors, your pharmacists.
And if you are taking multiple meds, don't hesitate. Ask if a formal medication review could be beneficial.
Definitely.
And it's also worth thinking about that bigger picture, how changes at the system level can help make medication use safer for absolutely everyone.
Good point. We encourage you to explore the resources we mentioned, ISMP Canada, info on MTM, learn even more about this really vital area.